here at our normal time. We'll do your guys' final exam, and then really just kind of wrapping things up for our class. And then if you need to take the retake the comp predictor, that will be during week 16. So it will be like it's been in the past, where Jamie will send out like the sign up and stuff like that. So I'll have to talk to her. I don't know if we'll just have like a time for like the retakes for comp predictors for us, just since our exam time is slightly longer than everyone else's. So yeah, Tiffany's good question.
Okay, so at the bottom when it says 10 points score improved, is this the predictability score improved or the overall score?
Predictability score, because if your overall score improves, your predictability is going to improve. So yeah, so if you got 90% or above passing predictability, like it tells you like what score you earned, and then it gives you your predictability. And so we're looking at the predictability. So if you got 90% or above, you get the 80 points, don't have to do remediation, don't have to do the retake. So with that, like, that doesn't mean that you should be done doing NCLEX prep, NCLEX questions, things like that. I still encourage you to do prep, things like that. Look at your report, and I can sit down and go through your report with you as well to see kind of what areas you need to focus on as we're preparing for NCLEX. And then if you're in that 85 to 89 passing predictability, you get 60 points. And so this is the way that we earn the points back. So if you do the remediation, you get 10 points. So that takes you up to 70 points. And then when you do the retake, if you get 90% or above passing predictability, then you'd be at the 80 points. You'd get the full points. If you improved, then you would be you'd earn then 75 points out of the 80. So 76 or above within that range, you do the remediation, you get the 20 points. Again, knowing that remediation might be a little bit more if you're a little bit lower in your predictability, so having you earn more points back for that. So I'd put you at 50 points, and then so doing a retake, the highest that you could get here would be, let me do the math, 70 out of the 80 points. And then 75% are below passing predictability. 30 points for doing your remediation here. So remembering that remediation needs to be the active learning templates. They're going to be handwritten that you would then turn in here. So then retake required, you can earn 30 points back. So again, here you can get a total of 60 points if you got below the 75% predictability. What questions do we have right now? So regardless, like doing remediation, doing the retake, like you're going to earn points back, no matter like what your score was.
Okay, so it's not the individual score?
No, it's the predictability. Do you have yours pulled up?
Yes.
Yeah.
Yes,
So-
I got it.
So yeah, so it'll be, yes, that, not that. Yeah, not not gonna be the individualized score. They have the predicted passing, so passing predictability. So looking at the score that you earned on the exam, then through ATI, it predicts what your how your chances of passing NCLEX. So if you're got in that 90% or above, they're statistically speaking, what they have, their data, you're 90% likely to pass the NCLEX with where you're at right now. Does that make sense? What other questions do we have about ATI and the comp predictor or VATI, things like that? We're finishing up.
So if we don't do the rest of this stuff in the VATI, nothing will happen, right? I mean, like,
You just
we'll miss
won't
out on
own
the
those
opportunities.
points.
Okay.
Yeah, you won't earn these points here.
All right.
So if you don't do VATI, you don't get those 40 points.
No, but if we do like those first 4 things that we have to do all the way up through med
Oh yeah, like if you don't continue with VATI after this, is that what
Yeah.
you're asking? No, it's
Okay.
just, yeah, it's like an NCLEX prep thing that you've already paid for, so.
Okay.
Yep, but you still have access to it after graduation. Yep. Yeah, Tiffany. Tiffany, did you have a question?
So, for the pharmacology thing, it shows my thing is complete, okay? Green
Mhm.
check marks, everything. But she messaged me last night saying she was gonna send out another assessment. Do I have to do that?
So probably just to help you prepare for like pharmacology, cause we know that pharmacology is hard and it is like a big gap area for all of us, on NCLEX, and there will be pharm on NCLEX. So everything, like, it's just based off of what the ATI educator recommends for things to do, so I can see what you guys have done and if things are done when they upload the report, but I don't have any control over, like, or say what to do for the assignments and things like that.
Cause
Yeah.
she sends me an email like every day with more stuff to do,
Yeah.
and it's just like a lot. So,
Mhm.
like every single day she sends me more and more, and I'm like, so
Just a gift that keeps on giving,
I'm just curious.
She wants you to be successful in NCLEX.
Yeah, well.
Cause yeah, it's better to put in the work now and be successful on that first time and not have to like do more work, get out there and get practicing, right? That's coming up soon. What other questions do we have? I'm seeing none. What I did is I just kind of pulled some questions, that we can, work through, talk through, and then this way we'll be able to, talk through things as well with like questions over like the concepts and content of what we covered here. So different snippets of the different areas that we covered while we went through this semester, just remembering that everything kind of ties together. There's a lot of overlap when we talked about safety. You know, that can tie into quality improvement. When we talk about scope of practice, that ties into delegation, remembering like our prioritization, all of that here. So we have, a nurse is unfamiliar with the prescribed medication. Which of the following resources is best for the nurse to find up-to-date information about the medication? So what would you guys utilize? You're in practice, what would you guys utilize to find up-to-date information?
Just in general, I would pick D, but if it was like a specific patient situation, I might call B.
What are other people thinking?
I remember this question on ATI, and the answer was call the pharmacist. And I was really confused by that.
It's not called a pharmacist, we wouldn't do
What
that.
ATI told me.
This is from ATI, and this is.
Really?
Mhm.
It was on the farm
Mm.
portion. And that's why I was really confused.
So, like, I mean, depending on what the question was, it could have been worded differently, so, or like a different type. So like, with looking at this, like, you know, Kimberly mentioned like a specific patient situation, you might call the pharmacist, but remember, like, that would be then kind of reading into the question too much, cause we're just unfamiliar with the prescribed medication. When you're at clinical, when you've been at your preceptorships, if you're not familiar with the medication, what do? Look it up, and what do you use to look it up?
Google.
Micromedics or.
Yeah, the micromedics, drug resources. So like micromedics would be a pharmacological electronic resource. So that is always going to be up to date. You know, you guys had Nursing Central, for a while too, that you could utilize to look up your medications, things like that. So if you are looking things up on Google, what do we need to be sure of?
From a reputable source.
Yep, that is a reliable source. So how can we ensure that things are reliable sources?
.gov is usually pretty good.
.gov, probably if you're going to the actual like manufacturer's website, it's probably reliable information as well. So yeah, so we're going to look it up with our resources. So it could be electronic resources, it could be an up-to-date drug book. So I don't know, some units might still have a drug book on hand or a drug manual, but so much of it is embedded within the electronic health record and the MAR there. right. And nurses in a hospital unit are discussing the principles of quality improvement and client care. Which of the following statements by nurse indicates a need for further teaching? So we're thinking about quality improvement.
Indecent.
Did I have indecent? Did I misspell? Oh, yeah. Yeah, you need to complete an indecent report. You did something indecent, so we need to fill out that. So what are we thinking? So what is the question asking us specifically? Okay.
Oh.
So yeah, reading what the question is asking us. So looking here, we need, indicates a need for further teaching. So we are looking for the statement that is incorrect. So A would be correct. So risk managers are A is correct because it is an incorrect statement. Risk managers are responsible for completing an incident report when a sentinel event occurs. Who's filling out the incident report? Who fills it out? Yep, the nurse that witnesses it.
So what is the risk manager, or what is that what it's called?
The risk manager?
Yeah, what's their, role in this, in incident report?
So they're the ones that are going to be like looking at the data and working on like mitigating or figuring out what's going on, can track some of those trends. So then our nurse managers are going to use those incident reports to improve client care. Completing the incident report for near miss demonstrates an effective strategy for quality improvement, because like we talked about, that's when we can, kind of ties into D, help track trends and identify possible systemic issues so we can work on quality improvement. So is this medication consistently having errors with it? So what can we do to help with that and prevent the errors from happening? So when incident reports are filled out, where do they go? Well, like risk management is going to look at it, nurse managers are gonna look at it. Where all is it filed?
I have no idea.
So where is it not filed?
The patient.
Yeah, so it's not gonna be filed in the patient chart, so it's just like, filed away for like nurse managers, risk managers, to look at and assess that data and see what's
Where?
happening to track those trends, huh?
Like where?
It's, within like so, you know, for example, if you're doing it on, Epic, there's a spot in Epic where it would go, it's just not going to be in the patient's chart itself.
So
Yep.
you do not have to send it to risk management when you complete it?
No, so what's gonna happen is like it all gets filed away and it gets sent away, so like, so Broadlands uses, Meditech, so I would just go into a specific spot in Meditech and like not through the patient's chart or anything, and fill that out for it, when I would have to do an incident report. Okay, but it does not go into our client's chart. Questions about that? Nurses reviewing confidentiality with a group of nursing students. Which of the following actions by a nursing student requires intervention? Bless you. Okay, why B?
Because you're never supposed to look up information of other patients that you're not taking care of.
So the information that you need to know about a client is like a need to know basis. So you're assigned your clients for the day, those are going to be the clients that you can look up the information on. But you know, like if I'm like, hey, Joanna, can you administer medications on my patient in room 7? You can go into that patient's chart and look up the information so that you can safely give those medications. But we're not going to be searching information about a client from another unit. That's why like when you guys would have to pre-assess, you'd have to go to your unit and look it up there, because otherwise we have gotten, emails, from the hospitals in the past wondering why maybe someone was looking up a patient on a different unit when they were logged into a computer on another unit. So they do, track that and keep an eye on that. So we're working with confidentiality. We are able to print client's name on a therapy schedule, because, you know, if you're thinking about like the stuff that's like on the, like nurses station, all of that stuff, that's just for nurses to view, or, you know, PT or whoever it might be. And then of course, we're always going to log out of our computer when we are done charting and not leaving it open. That too is also, you want to protect your license. You don't want someone to sit down and start documenting under your name. You get called into court and you're like, I really have no idea who this patient is because I did not ever take care of them, but your name's on the chart. So again, that's to protect your license as well as confidentiality. What questions do we have about this one? A home health nurse is invited to dinner by a client. Which of the following actions by the nurse indicates understanding of professionalism? So you're invited to dinner by a client. What would you do? What would you do in this situation? So nurse would you accept the invitation, decline the invitation and refuse to care for the client in the future, decline the invitation but offer to extend the length of home visits, or decline the invitation but say that you can accept a gift card to a restaurant?
I think it depends on whether it's like a guy asking you out or it's an old lady asking you out. You know, because for an old lady, I'd be like, well, I can stay here a little longer, you know, but for the guy, I'd be like, I'd kind of feel awkward. I don't know.
Like you shouldn't accept a gift card.
Yeah.
Um,
Can't accept
I
those
guess
gifts.
maybe C.
Okay, so you said B or C, so what do you guys think? What are-
C,
C, and why C?
because you probably shouldn't refuse to take care of a patient because of an invitation.
Mm-hmm.
And D is definitely wrong. And then C, I guess that's the only one that's the most acceptable.
Cause you can offer to maybe like extend the visits for a little bit, because you're still then caring for them. You know, you can talk to them about, you know, professional boundaries, things like that, why, you can't accept the invitation. But that when you come for your home visits, maybe you could extend that length a little bit, longer to address any like concerns. And sometimes, you know, it just might be that they're lonely and they just want someone to talk to for a little bit longer. So C, it still addresses the client's needs. So thinking about, what we can do to still care for them. And yeah, you wouldn't just decline an invitation, like, you just wouldn't refuse to care for a client, in the future just because they invited you to dinner. I got asked out one time, he wanted to take me to Applebee's because it was 2 for $20, so felt really special. He was with his aunt was with him, and he was there because he had a gunshot wound, but it was an old gunshot wound, but it was giving him problems and everything like that. And his aunt was like, do you really think she wants to go out with you? Like, it was funny, so yeah. Wants to take me to Applebee's because it's 2 for $20, so I told Adam, like, it was before we were engaged or married, so, cause he was like, I don't see a ring on that finger. Okay. A new nurse tells their preceptor that nursing is more stressful than expected and that they are concerned they will make a mistake. Which of the following statements by the preceptor is appropriate? So thinking about communication. So read over the policies and procedures manual on your time off. It is important for you to ask questions when you need to. Make the most time-consuming care your priority. Ask the charge nurse to give you easy clients until you are more comfortable. B? Yep, so B is correct. So it's important for you to ask questions, ask for help. You are not on an island. It might feel like you're on an island at different times, but you're not. When I started work in the emergency room, my orientation was scheduled to be 3 months. and then at 3 months, we were going to sit down and evaluate if I was ready to come off orientation or if I should continue on. And my nurse manager and supervisor and preceptor told me that they were comfortable taking me off of orientation because I did not hesitate to ask for help when I needed it, and I didn't hesitate to ask questions, and I was going and I was looking things up and being proactive in that way. Policies and procedures manual, like, yes, you're gonna reference that, but it's not necessarily gonna help you, you know. It will help you, but it shouldn't be doing that in your time off. You should be referencing that at work when you need to. It's not necessarily gonna prevent you from making a mistake here. You know, most time-consuming care, your priority, yeah, we're gonna be working on prioritization, but that's not going to help with making a mistake. And having the easy clients isn't going to really help you improve as you are going through orientation. The nurse is entering data in the client's electronic health record. Which of the following protects the integrity of the data in the EHR? So how is everything protected? So like web requests or the internet, automatic logout, authentication, or a unit ID and password.
I'd probably pick D.
D?
C.
C? So what's the difference between D and C there? So what's the key word in D that would make it incorrect? Unit. So that would be like thinking that, like, okay, we all work on the same unit, we all have the same username and password.
Oh,
Yeah, so unit there. So then the authentication, you know, we have the different ways that we verify who we are, you know, your username, passwords, we all have our individualized username and password that we don't share that with, you know, badging in and out. Like I mentioned, some places have, you know, the fingerprint, so automatic logout, yeah, there's automatic logout, but it's after it's not being used for like, I think like 5 to 10 minutes, so that's quite a while, that someone can still come in and look in the charts. And then, yeah, the internet isn't going to really help protect the integrity of the data here.
So I read that like my own unit
Oh.
ID and password. Like I never would have thought we all have.
Yeah.
that, you know, man.
Got it, I see how you're reading it, yeah. It's the fun thing about NCLEX, right? The wording of certain things. Okay, so a charge nurse is teaching a seminar to staff nurses about informatics and client care. Which statement by a nurse indicates an understanding of the teaching? So we're talking about informatics. So reviewing trends of vital signs and submission is part of informatics. I will use informatics to monitor the use of airborne precautions. I do not need to use informatics when conducting a focused assessment on a client. A. Yep. So A, we're gonna track those trends in our vital signs and submission. Always important to look at the trends. Is it someone that tends to, you know, maybe like blood pressure, heart rate run a little bit lower? Where have they been at? So why is informatics important to identify trends when we're caring for our clients? Why are we looking at, like, you know, the trends of their vital signs, the trends in their labs? Why is it important?
Because you have to report a change in status to the provider.
Yeah, have to report a change of status to the provider. So tracking those trends helps us identify those changes, and then that's going to improve that client care. So if we're picking up on those changes, even if they're like those subtle little changes, we report that to the provider, and we can do intervention sooner and improve client care and client outcomes there. A nurse manager suspects that a nurse is under the influence of alcohol while at work. Which action should the nurse manager take? Provide personal counseling to address the nurse's substance abuse, call the police, schedule a meeting with the nurse within 48 hours, or arrange transportation home for the staff nurse. What would you guys do? If you're the nurse manager and one of your nurses comes to work under the influence of alcohol, or any substance for that matter.
Would you call the police?
I'll call the police.
Send them home.
What was that?
Send them home.
Yeah, you're gonna send them home, cause you're protecting the safety of the clients on the unit. So you're gonna send them home. You will schedule a meeting with them, but it needs to be within 24 hours, and then kind of address the concern from there, and set them up, see what needs to be done, and kind of follow up. Can get Board of Nursing involved as well, so you're not gonna call the police.
I did see there was like a teacher that went to school drunk and they called the police on her.
Oh, yeah,
So that's why I thought maybe if you're
Would be
taking
that,
care
yeah.
of patients, it's probably
yeah.
against the law.
I mean, if they were being like, belligerent and being destructive and things like that, then you'd call the police, but yeah, you would just arrange transportation home for them, like pull them aside, talk to them, arrange transportation home so that they get home safely. And then clients will be safe too, because they're not gonna be able to think clearly and make good decisions there. And then you wouldn't do personal counseling, you would see, like, kind of get them set up with resources there. A nurse is resolving a conflict about client care during a meeting with members from different departments. Which of the following types of conflict is displayed? So we have conflict, between members from different departments. C. So we had
B.
interpersonal, yep, B.
B, sorry.
I was like reading through, I was like, yeah, so intergroup conflicts, because we have, so commonly, ED nurses and ICU nurses, I mean, we get along, but we don't, because the ICU wants us to have like tons of stuff done on our clients, and we're like, no, we got them stabilized, here you go, type of thing. It's not ever really like conflict, it's just different of what the expectations there. But it could become intergroup conflict, since it's between the different, departments there. Interpersonal conflict, what one is that? So intrapersonal.
Isn't that with like two people on the same unit?
So interpersonal is gonna be like conflict within yourself here.
So intrapersonal.
So then the interpersonal conflict is gonna be between like two or more coworkers when they disagree on things. And then what's our latent conflict if we're thinking about?
I'm confused, cause you just said the same thing twice.
No, I said intra,
Is inside.
inside
Yeah.
me, and then inter.
I thought you asked about inter, that's why I said two or more.
Oh, okay.
Yeah.
So yeah,
the
intra
A
is between
inside or
maybe,
out?
A is in,
Okay.
inside, and then like interpersonal conflict is between like a couple nurses within the unit, but like two or more, like if there's conflict between two or more nurses there.
And, intrapersonal be like on the same unit, or is that a thing?
Well, interest like.
Or
intra-
Is, yeah, intra,
Intragroup, I mean. What would
In-
be between two people on the
interpersonal?
same unit?
so if it like,
Is there an intergroup?
Because this one
I need to
is,
stop listening.
So the top one is within yourself.
no, I know, okay, I know that. A meeting with members from different departments, what if it was between two people in the same department?
so if it's between two people within the same department, then it'd be interpersonal conflict.
Okay, sorry.
Yeah,
And then the
where then if you're
top one is-
having, like, say the emergency department and the ICU, they're feuding, so that's
And
in,
then the organizational, that's
intergroup.
like different hospitals or something.
yeah, organizational, yeah.
That's okay, I'm also like,
And then latent conflict, that kind of goes through like our stages of conflict, so what's latent conflict?
A late conflict.
Not a latent conflict.
Has it been there like for a while and hasn't been addressed?
So it's when there's kind of like the perfect storm for a conflict to happen, but it hasn't happened yet. So it's when it's something, there's a likelihood that it could. So it hasn't happened yet, but very likely that it could. Things are just kind of brewing up, and so it very well could happen. A nurse is preparing a teaching session for a client who does not speak English. his adult daughter is present and is fluent in English, which of the following actions is the most appropriate for the nurse to take? So request a bilingual nurse to interpret the teaching, ask the client's daughter to read and interpret the teaching, contact a medical interpreter to translate the teaching, or provide the teaching to the daughter in a quiet room. C. Yep. So we always want to have the medical interpreter available, because then we can ensure that things are actually being like translated to the client. And then just we know like healthcare language is completely different. So might not always be familiar with the terminology that's needed within that language. So even if you don't have an in-person one, there's language lines you have like the teleinterpreters that we can use as well. So kind of going back can help with that information technology there, so we can find one available to us. So typically, if you need to have a teleinterpreter, they have so many different languages available to you. You would just call them and they would get you set up with that interpreter if you don't have an in-house one available. Nurse managers reviewing the advantages of electronic medical records with a newly licensed nurse. Which statement by the newly licensed nurse indicates a need for additional review? So electronic medical records inhibit continuity of care. Electronic medical records facilitate quality improvement. Electronic medical records prevent duplicate tests from being performed. And electronic medical records reduce cost of care. A. Yep, so they're not going to inhibit the continuity of care. They're going to enhance continuity of care. Electronic medical records, we're able to track, trends, help with quality improvement. We can review like tests that have been done. So we're not doing duplicate testing, whether it be like diagnostics or labs, or we can see what medications have been trialed on clients and weren't successful. And in turn, that does help reduce the cost of care for our clients, so we're not having repeat things done. And then kind of having that continuity of care and being able to see the whole picture is really nice. So which of the following actions by the nurse is the best defense against malpractice? What's the best thing that we can do, the best defense against malpractice? Kind of protect ourselves, best thing.
A.
A? Why are you saying A?
Because if in a chart it didn't happen,
Mhm.
like you're not gonna remember everything you did, so
No.
if you get called to court, you're just gonna look at what you wrote down.
Yeah. Yep, so A is correct, because you want to have complete and accurate documentation, because like Kimberly said, if you didn't document it, it didn't happen. Also, it's not like something happens and then you're called into court for malpractice like 2 months later. It's going to be years down the road, and how many people have you taken care of between that client and now, when it's been years? A lot of times it will be like the client too, that you have the memorable ones in your head. It could very well not be that memorable client that you're like, I don't remember anything about this. So what they're gonna present to you is your documentation, and that's what you have to go off of to like remember how you cared for that client. So yeah, like we're gonna clarify prescribed medication with the provider over the phone, or like repeat. We want to include up-to-date information, so we're going to be doing that. D, we're not going to have the charge nurse double check all of your work, so it's kind of on you. So remembering malpractice and negligence, so kind of reviewing that. There's a question in here, so we'll get to it. A nurse is using the SBAR communication tool to report the condition of a client to a provider. The nurse should include the most recent treatments in which component of the communication. So if we're using SBAR or ISBAR. So what's included in the situation? So I call like, hi, Dr. So-and-so, this is Rachel from whatever, what's in situation.
What the patient is in for.
So yeah, so if we're looking at, the situation, we're looking at the, name, your name, kind of the ISBR, your name, the client's name, and then the problem that led to the call. So you can say that, you know, like, Mr. Jones in room 8 is having worsening shortness of breath, or blood pressure is increasing, and is this. So what's going to be in our background? Recent treatments, diagnosis, medical history. So maybe it's that client that's having increased shortness of breath. Maybe they were admitted for a heart failure exacerbation 3 days ago. We've been giving, 40 milligrams Lasix, however many IV, however many times a day. Last dose was at whatever time. So what about assessment? What's assessment?
What your assessment on the situation is.
Yep, so assessment on the situation. So if someone that has heart failure and they're having increasing shortness of breath, probably having, some pulmonary edema, fluid overload there. And then what's our recommendation? What's that gonna be?
What you recommend.
Yeah, exactly. Like, what do you recommend? What would you like the provider to do? Do you think they need to come and see this client right now? Do you think that they could, maybe order some labs and maybe some medications, things like that? So I think with SBAR, the thing that trips people up the most is like assessment is going to be your assessment of the situation. What do you think is going on here? So like the background is where like our recent treatments are going to be going in. So the answer to this would be C within our background.
So is background also vitals?
Yeah, we could have our vitals in there, yep. I think this is something that we do it, naturally. Like if you have time when you start calling the providers, if it's not an emergent thing, you can, kind of write out a little bit of what you want to say. But I think it's something that when you like break it down into what's in each thing, we can overthink it sometimes, but if we're just doing it, then it's a lot easier. So this was created just to help facilitate that communication, when you're calling your healthcare providers for orders or change of status, things like that. So if it's SBAR, the I is just the introduction, so just that reminder to introduce yourself. A nurse is caring for a client who is unable to make decisions for himself. The client's adult children disagree on his code status. Which of the following sources should the nurse depend on for decisions regarding the client's end-of-life care? Client's oldest child, the attending provider, the client's healthcare proxy, or the facility's ethics committee? C. Yep, so we're gonna use that client's healthcare proxy. So this is person that the client chose to make their decisions for them. Ethics committee could be involved if there aren't like any advance directives present, or say there's a client that doesn't have like any family or support system around, there's like no next of kin, they can't find anyone for them. That's when ethics committees can get involved to kind of make the decisions for that person if they're unable to. So what are our advance directives? So we always have to ask if a client, every time there's someone, we have to ask if they have advance directives or a living will. What are our advance directives?
Like their wishes in regards to their health.
Yeah. So what would they like to have done if they could not make those decisions? So wishes regarding the end of life care. What do they want to be done? So then what's our living will?
Isn't that more like who stays with your things?
So,
Or who would have say over you if something happened?
So yeah, so living will, it's a big, long legal document. So like Joanna said, that's where you can say like, I want like this to go to, like, oh, I want my house to go to so-and-so, and I want, you know, that's gonna be kind of looking at that. But it also, does express their wishes to medical treatment. And a lot of times in there, they can mention the person who they want to make those decisions for them. And then your durable power of attorney or your healthcare proxy is going to be that legal document that appoints someone to make those decisions for you. So
You
like,
said durable what? Sorry.
durable power of attorney, yeah, power of attorney. So like my oldest sister, she's not married and doesn't have kids, so I am her durable power of attorney. She appointed me to be her durable power of attorney like a few years back, so we just have that. So again, these are always like the conversations that you should have with like your family, just so that they know. So even if you don't have advanced directives or a living will, have the conversations with your family so they can kind of have an idea of what you would like to have done if you end up, you know, we all think that it's not, you know, oh, I'm healthy, I'm young, but you never know what's gonna happen here. Charge nurse is making assignments for an oncoming shift. Which of the following clients should the nurse assign to the LPN? So I have a client who is to be discharged with a PICC line, a client who's confused and awaiting transfer to a long-term care facility, client who's 16 hours postoperative following a total laryngectomy, or a client who is newly admitted for abdominal pain of unknown origin. Who can the LPN take care of?
Okay, now when we get these kind of questions, should we assume that there are like assistive personnel available? Like, because is this looking for something specifically in the scope of practice of the LPN? Like, cause sometimes I think, oh, they could do this, but that could also be done by an AP and I've missed it before.
Yeah, so yeah, we're looking at stuff that for the LPN specifically, so yeah, yep. Does that answer?
Yes, it's just like,
Cause,
I'm probably gonna confuse everybody.
well, I mean,
when
no,
keep
well,
talking.
cause if you think about it this way, so like, as the RN, yeah, we could ambulate clients, we can do those baths. But when we're like looking at delegating to another RN or assigning to another RN, we're gonna do something that is within their scope of practice that someone else can't do. Like those questions, so it'd be the same for like the LPN.
So that, it is safe to assume there are other staff that could take the things that, like, that are easier, like the APs.
Yeah, cause I know like in the past, we've had questions of maybe it was like, say one of these answers was like the client, that needs, like monitoring of strict I's and O's, you know, like that's something that the LPN, I mean, not the LPN, but the UAP can just document those I's and O's, so I understand what you're asking, yeah.
It's like, I'll know the answer, but it's not it's the psychology of the question.
Yeah.
Like, what you can read into it and what you can't.
Yeah, so just, yeah, trying to prevent from like, yeah, reading into it too much and just knowing, looking at what the LPN can do. Cause like, yeah, all of that, you know, stuff is within our scope of practice too as nurses, but we're like going to think of like the UAP will do that or the LPN. Does that kind of help clarify
Yeah.
some? Okay.
Is it D?
B? So why B?
It's not D because they were newly admitted and they're probably not stable. C, it's 16 hours, so they have to be 24 hours for them to take care of them.
Okay. And what's a laryngectomy?
Throat,
Mm-hmm.
airway.
Airway. What could happen with her airway?
Aspirate or,
Yeah, just like, yeah, swelling, all of that stuff.
and then A probably requires teaching.
Mm-hmm. Teaching, yeah, especially with their being discharged with a PICC line, requires a lot of education. So just remembering and thinking back to scope of practice too, what it is our LPNs can and cannot do. So remember, they can't do those new assessments. They can't do that education. Like that new education, they can do that reinforcement. They can do like reassess, but they can't do those new ones. What questions do we have about like the LPN scope of practice versus the RN? A nurse has received a report on the following clients. Which client should the nurse assess first. So a client with a history of cholecystitis that reports abdominal pain, that's 5 out of 10. Client experiencing stridor, a client with a history of COPD that reports increasing shortness of breath, and a client with chronic hypertension whose last blood pressure reading was 146/94. B, what's stridor? Bad. Yep, that's our airway issue. So everything's stridor, remember there's some type of like airway obstruction, whether it be like choking, a foreign body, inflammation, swelling. So stridors are airway. So if we're doing our prioritization, ABCs, so it's the B, C, D, and then A from there. So just remembering our prioritization, remembering what stridor is. A nurse is evaluating conflict resolution between two staff nurses. Which of the following conflict resolution styles is an example of one nurse putting aside her own goals to satisfy the other nurse?
It's that combination.
So accommodation. So one nurse is just putting themselves aside and just going along with the other nurse's goal. What's avoidance?
To avoid the situation.
Yeah, just avoid the situation. Don't want to deal with any conflict, so I'm just gonna avoid you, avoid the situation. What's compromise?
That other nurse would also be giving something up.
So they're both giving something up to reach that common goal. And then what's collaboration?
Like talking about it equally.
So they're going to actively be working together, identify that common goal and work together to achieve that common goal without anyone really having to give anything up. So yeah, this would be an example of accommodation, because one nurse is giving everything up and the other one's not. Compromise is both are giving something up. Collaboration's the best one, but it takes the longest because you're having to actively work at things to meet that common goal there. Healthcare team is performing CPR on a client in cardiac arrest. Which of the following types of leadership is best for this situation? So what's transformational?
It's like inspiring when the person is not required to be a leader in your life, but they're like, you should really further your education, you know, you should take the situation, you can handle it.
They empower you, they inspire you to be better. So that's that transformational leadership. What's the laissez-faire? Laid back, more of a hands-off approach. So, you know, you kind of have to be able to trust your team to have that, be able to do laissez-faire leadership. So not micromanaging so much. What's transactional?
If you lose, we get a pizza.
Right. Get a pizza, you get candy, here you go. Like, oh, you're in, like, things are, you know, aren't going well, here's a pizza. What's autocratic?
Why is it said like that? I thought it was the
Bureaucrat.
Oh.
It's
There's-
a combination in between.
There's autocratic and authoritarian, like it's used interchangeably, like
So
if you
it's the
read
same
thing,
thing?
yep, if you read,
Okay,
yeah.
that's
Maybe
right.
we learned a new word today.
So what is that then?
Like someone telling you what to do.
Mm-hmm.
I definitely thought all of these were wrong. I was like, I don't know I didn't know what the bottom one was. So I was like, I probably would have picked a different one.
So going through too, then, just using test taking strategies, if you know what transformational is, laissez-faire and transactional, if it doesn't seem like those would work in this situation with CPR, go with D. Like even if you're not 100% sure what it is, you could go with the one that you're not sure of if you know the other terminology. So then the other one you guys mentioned was bureaucratic. What's bureaucratic?
All the paperwork and
Yeah.
charting and stuff, you have to get through things.
Yep. So following like the policies and the procedures, and then democratic. What's democratic?
They all work together, right?
Yeah, working together. It's not, so bureaucratic's gonna be more top down. Democratic is gonna be including everyone, in decisions. Communication is up and down, so tends to go more up the chain of command. Two more here quick. A charge nurse receives a call from the nursing supervisor about a derailed train and an urgent need for beds for newly admitted clients. Which of the following clients should the nurse recommend for discharge? So I have a 70-year-old with a history of type 2 diabetes admitted 48 hours ago with uncontrolled glucose levels. A 54-year-old who was 12 hours post-op following a total knee replacement. An 80-year-old admitted 24 hours ago for vomiting and dehydration. Or a 44-year-old who has asthma and was admitted for a carpal tunnel surgery. D. Why D?
Because you can
Because
wait.
they can wait.
Yeah,
And
they
I
can
missed
wait.
it on the test.
Yep.
Not gonna miss it this time.
And so, like, the asthma here is thrown in as a distractor, but are they admitted for their asthma? No, they have a history of asthma, but they're admitted for an elective surgery, so they can wait. Everyone else should continue to be admitted. So a client in a long-term care facility falls out of bed but is uninjured. The side rails on the bed were not raised at bedtime, although the client was identified to be a fall risk. The nurse should identify that which of the following torts has occurred. A, negligence. Why negligence?
Because they're being negligent.
Yeah, being
They
negligent.
weren't injured.
Yeah, they weren't injured, so if there was an injury there, could go to malpractice then. But yeah, they were being negligent, so they didn't really follow like the standard of care. So if the question was, that the client fell out of bed, broke their hip, the side rails on the bed were up, the client was identified as a fall risk, things like that, what would you think it would be at that point? Malpractice still. Why malpractice still, even though they broke their hip? Why would it still be malpractice?
Because they did everything they were supposed to.
Yeah, they did everything that they were supposed to. So, they did the fall risk assessment, identified the client was a fall risk, had the rails up, had all of the safety things insured, but the client still got up and fell out of bed, so that would still be negligence there. So just reviewing, with malpractice or that professional negligence that we need, our duty to provide care, we have that standard of care, knowing that there's a breach of duty, the foreseeability of harm, and then the breach of that duty has the potential to cause harm, so kind of the 2 and 3 together, and then that an injury does in fact occur there, so whether it be an injury or death there.
What is it called when you threaten a patient? Like, I'm gonna put you in restraints. Is that assault or battery?
Isn't that assault?
That's assault. So
Okay.
battery is like actually physically harming them.
Those never make sense to me.
Cause then those are on the comprehensive predictor. I
Yeah.
took twice.
Yeah.
I was like, well, I'm either right twice or wrong twice.
Yeah, just go with it, like, yeah, and go. So yeah, so battery is like actually physically, assault is like brutally threatening them,
So it would still be malpractice if the nurse was doing everything they were supposed to and the patient got hurt.
That would, be most likely found as negligence, because they did everything that they were supposed to do. So in order for malpractice or that professional negligence, we need to have like the, duty to provide care, we need to like not, so if we, for this, if the client broke their hip and were injured, then it would be malpractice, because we did not put the side rails up. We knew that they were a fall risk. We saw there was a foreseeability of harm. We didn't follow that standard of care. But if we follow that standard of care, we do the fall risk assessment, we have the side rails up, we do everything we can to prevent injury, and the client still falls and breaks their hip, that would be negligence, just because, or might be even completely unfounded with stuff, because we did everything we were supposed to do. Does that help?
Yeah, yep.
Yeah. So yeah, just making sure that you're following that standard of care that's been set. And who are they gonna call in if you go to court? I'm in the emergency room, I'm an emergency room nurse, I get called in for a negligence case, who are they gonna call in to as
Other
witnesses?
emergency nurses.
Another emergency room nurse, that's who's gonna be able to define that standard of care for us. What questions do you guys have?
For that type of question, would it be like somebody that's in the facility, or could it just be Or would it have to be like random emergency nurses?
Probably,
so there's no
another
bias?
emergency room nurse for conflict of interest, because if it's like, you knew me, like you would probably be testifying to protect me. So like one of my, friends that I worked with at Broadlawns, she was, you know, a nurse expert, so for, trials and stuff like that, and I'll have, one of my, good friends is an attorney, and he'll, you know, kind of consult me with certain things too, so I've never had to go, like, be an expert witness, but he's, you know, consulted me for things in the past, so.
So what if, like, would it be someone from your hospital or anywhere, cause you know, like, some hospital, like, they do things a little differently?
Yeah. So the standard of care is gonna be like the same, like throughout all departments of that specialty of nursing or that area of nursing. That standard of care is the same. Policies and procedures, of course, could be a little bit different, but that standard of care is gonna be the same. So they're likely not going to pull someone in from your unit or from your organization, because again, that conflict of interest, we're gonna, you know, either knowingly or unknowingly try to probably protect that nurse, so. Anything else?
I do have a question.
Yes.
For, triaging for spontaneous breathing, so if they
Oh, yeah.
are spontaneously breathing, you reposition their airway first?
If they are not,
If they are not?
yeah, if they're not spontaneously breathing, then you reposition their airway.
So spontaneous is normal?
Yeah, spontaneous is I'm laying on the floor, I might not respond to you, but I'm breathing on my own,
Okay.
yeah.
Cause I thought that was the opposite.
Yeah, voluntary breathing, yeah,
Okay.
yep, yeah. Yeah, so like if you know, you walk in, you find me and I'm unresponsive to you, but I'm laying there and I'm breathing on my own. But if they're not breathing, you reposition their airway, see if they start breathing or not, and then kind of go from there. Alright. Well, I hope everyone has a good weekend. One more. Oh. Oh, okay, sounds good, perfect, thank you so much. See you guys later.